are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to the Addiction Files, and we are thrilled. It is our honor and our privilege to have Dr. George Koob from the National Institute on Alcohol Abuse and Alcoholism, or the NIAAA, joining us. So it is our privilege to have you here today. So thank you so much for joining us. And if I can just indulge for just a minute, Dr. Koob, I remember this probably would have been back in 2008 or 2009. I was just coming out of residency and in my training, and that was probably the first time. I have heard you speak many times, but that was probably the first time I heard you speak. And you gave one of your lectures on just the neurobiology of addiction, and I was hooked. It was just so fascinating as you were going through and teaching us. And that was what I was seeing in my patients, and it was just so clinically relevant. So I appreciate all your work over the years, and I'm really excited today to just talk about definitely some of the consequences, what we're seeing, and then what we can do to help our patients. So I'm going to turn it over to you to just, even though most in the addiction world, you need no introduction, but introduce yourself and then we'll get started.
Darlene, thank you very much for the kind words. I'm George Koob. I'm the director of the National Institute on Alcohol Abuse and Alcoholism, but I also have an active basic research laboratory at the National Institute on Drug Abuse, where we study what I basically call the negative emotional side of addiction and the neurocircuitry that's involved in mediating those kind of effects of drugs and alcohol. I still work on alcohol in both places. So
great. And then I think that's, where we really are interested. I think our learners will be really interested in hearing you speak about that, Dr. Koob. Alcohol is probably one of our favorite topics on our podcast. We have learners that are mostly medical, although we have a lot of behavioral health learners and educators and law enforcement, kind of everybody, and a lot of lay people. And because of this work that you've done with, the negative affect state that occurs in the brain and the central nervous system with people who are stuck in this cycle of either alcohol use or other substance abuse, I would love you to talk more about that and the work that you've done and the work that's ongoing over at NIAAA as well. Tell us a bit more about that.
So I'll try and make this as concise as possible, but it was a long time ago that I used to teach at the University of California, San Diego undergraduates about addiction. They were very large classes, and if you've ever tried to teach undergraduates about addiction, it can be challenging. So one of the things I did is develop a course called Impulse Control Disorders, and in the process of developing that course, I noticed that all addictions, not only drug addictions and not only alcohol addiction, but also non-drug addictions like gambling or compulsive eating or even compulsive exercise, they all had some common elements. And that's from whence came the 3-stage addiction cycle. And so I began to realize that there was some sense to the addiction process and how it evolved. And so we, at that time, defined a binge intoxication stage, which encodes reward, pleasure, incentive salience, a withdrawal negative affect stage, which is what everybody thinks of as withdrawal. But we were thinking more of the fact that during withdrawal, people are miserable, basically, in simple terms, and exacerbation or worsening of negative emotions. And then the craving stage, or we call it the preoccupation anticipation stage, which is, deficits in executive function, but characterized by a yearning and a real desire to retake a drug or re-engage in gambling, for example. And so over the years since then, and this was in the 1980s, we have basically, through a lot of research, and not just my laboratory, begun to understand that these 3 stages are manifest in human beings been validated that these three stages encode those dysfunctions that I talked about, and that they are mediated by different circuits in the brain. And so, the reward system is well documented, involves chemicals like dopamine and opioid peptides or endorphins, is largely focused on the basal ganglia, part of our brain deep in the front part of our brain that even lizards have a basal ganglia. It's what gets us moving, motivated, doing things, but also provides, the pleasure of doing things. And then the amygdala and circuits in the amygdala, fight or flight part of our brain, which is deep in the temporal lobe, mediate the withdrawal negative affect stage. And the cravings are frontal cortex, which is the one that's so slow to develop. In fact, probably doesn't fully develop in humans till early 20s, is what encodes executive function and mediates craving. And so, this is what we know as the three-stage cycle of addiction, but three functional domains and three neural circuits that are involved. And, the frontal cortex is kind of like your superego in some ways. It's controlling, your reptile brain, the basal ganglia, and the reward system, but it's also controlling your stress system. And so if drugs are affecting that, they're obviously then affecting your emotional systems. And if you put it all together, you realize that, people take drugs initially to feel good because they're activating the reward system. But ultimately, you end up basically taking drugs not to feel bad. And, that's a quote that I often use, but, what we forget is that feeling good doesn't last, all right? It's a word that's not used that much anymore these days, but you develop tolerance. And so, think of the first drink of alcohol you have at a party, and, that wave of relaxation that comes over you, a mild euphoria, and you feel top of the world maybe for a little bit of time, but that wears off after an hour or so. And so you might spend the rest of the evening trying to chase that pleasurable effect, and you don't regain it in its full flavor. And in fact, the more you drink, the more likely you are the next day to have a raging hangover, which, in my opinion, is a mild withdrawal syndrome. And if you think about that as a cycle where you re-engage, you end up trying to fix the problem with a drug that's making the problem worse. And so that's my mini view of alcohol use disorder, substance use disorder in general, and a kind of neurobiological framework on it.
Perfect. And so this notion, we've all been taught, I think, preliminarily about addiction as this reward system process, and yet this really speaks to this negative affect state, which then drives it much more probably than the reward, like you're saying, because of tolerance. And you talk about this term hyperkatefia, which, again, like Darlene and I were introduced during your scientific presentations at conferences, but it's not kind of a well-known term out in public. So do you want to describe that more? I mean, I know you've already talked about negative affect state, but can you describe that a little bit more? And especially the duration people can live in that state. It's not necessarily, is it short-lived? Is it long-lived? And is there anything that we can particularly do to target it?
Yeah, no, it's my favorite word because I made it up, and it's actually now you can find it in Wikipedia and on a search engine. Hyperkatefia was coined in 2010 by myself and two anesthesiologists that I worked with, medical doctors, Joe Sherman in San Diego, who has a clinical practice, and Howard Gutstein, who at the time was at MD Anderson Cancer Center. And it, I basically, there's a Koob story with everything. So my brother Steve is an archaeologist, conservator, speaks Greek fluently. So I called him up and I said, I need a word for negative emotional state in Greek. And he gave me katefia. And I just stuck hyper on it. Okay, it's that simple. So it's a hypersensitive negative emotional state. And it's analogous to hyperalgesia, which you both know as a state of increased sensitivity to pain, which could be caused by an injury. But hyperalgesia can also be caused by chronic alcohol use and chronic opioid use. And so that's hyperkatefia. And then actually, it was only last year I gave a talk at the alcohol and stress meeting in Volterra, Italy, and I coined the term protracted hyperkatefia, which comes to your second part of your question, which is some of these symptoms persist for months and years after cessation of chronic drug use and alcohol use and opioid use in particular. And so people call it protracted abstinence or protracted withdrawal. But I actually coined the term protracted hyperkatefia because, the physical signs that everybody always likes to focus on with withdrawal often disappear rapidly. And some drugs like marijuana and nicotine, and even cocaine, you're hard pressed to come up with physical signs. And if I may continue to preach, I don't think individuals with a severe alcohol use disorder are drinking because they have a tremor during withdrawal. They're drinking because they're miserable during withdrawal. Okay, they hurt all over. It's a flu-like state. They're irritable. They're cranky. Everything is gray. Nothing feels good. Pleasurable activities are no longer pleasurable. So you lose your reward system, and you gain your stress system in hyperkatefia, both of which contribute to hyperkatefia. You can think of it in simplistic terms that you've depleted the dopamine system, and there's some evidence for that. You certainly downregulated its activity. So, you're no longer getting that dopamine burst, but you're also heavily engaged and activated your brain stress systems, some of which drive your pituitary adrenal axis, but others just make you miserable, like dynorphin, which is, the opioid peptide that's aversive to every mammal I'm aware of, including human beings, when it's expressed and overexpressed. So these misery neurotransmitters are activated, and if you will, your pleasure transmitters are deactivated during hyperkatefia. And some of those effects, last for a long time, and they get re-engaged by a stressful event. And so you may be sailing along okay, and then suddenly out of the blue, this internal kind of state gets triggered, and it could be anything. It could be a reprimand from your boss, or it could be, some loss of a friend, or any event can trigger like a reawakening of this negative emotional state. And that often drives relapse.
Oh, thank you. That's awesome.
Where are we on current research and treatment options, and particularly for alcohol use disorders during this negative affect state? It is the most challenging clinically to treat when we have patients. We see it. I mean, you just described what I probably see daily in my office, but we feel like such a loss and helpless sometimes as physicians to treat this.
Yeah, no, that's a very good question. And I totally agree with you. I mean, I have more trouble convincing basic researchers about hyperkatefia than I do clinical researchers, because clinical researchers know exactly what I'm talking about. But rats express the same symptoms if you utilize measures of, rats will avoid places where they experience hyperkatefia, let's put it that way. So the answer is, in the alcohol field, we have a camprosate, which is effective. It helps some people. It basically blocks the glutamate surge that's associated with alcohol withdrawal. And glutamate's an excitatory neurotransmitter that certainly contributes to the irritability and some of the symptoms of hyperkatefia. A camprosate's not a terribly powerful drug, okay? If those of you who know about it, it takes grams to work 3 times a day. And actually, it's a taurine derivative. And most people don't even know that. It's calcium homotaurine. Taurine's a neuromodulator that's in our brains that's like GABA that suppresses activity. So presumably, acamprosate has some beneficial effects and can be used, but people have to take it. They have to take it 3 times a day. And usually it's recommended to be taken after you go through acute withdrawal. So that's another issue. But people find it useful, and there's some work at the Mayo Clinic where they've been able to identify those people who actually respond to acamprosate versus those that don't, and what biomarkers kind of indicate that. So there's been some progress in that regard. In the alcohol field, we don't have anything else really that's approved by the FDA that works on the hyperkatefia domain. Naltrexone, of course, blocks the pleasurable effects of alcohol, and that's effective as well. But there are some other medications that are on the VA formulary, and they're recommended by the APA as secondary treatments. One is gabapentin, which seems to help with some of the sleep disturbances associated with alcohol withdrawal. There have been some positive clinical trials. Dr. Mason at Scripps Research has done pioneering work in this area. And so gabapentin is one that's used. And then topiramate has been used in clinical trials, some positive clinical trials with alcohol and PTSD in particular. Each of these drugs have some form of side effects that have to be considered, but the only 3 approved by the FDA for alcohol use disorder are, of course, antabuse, which makes you sick if you drink, and then naltrexone and acamprosate. In the opiate field, you both know that there is buprenorphine, which is very effective, and that's a partial agonist, but it's often hard to get people off of the last few milligrams of buprenorphine. But it does treat the hyperkatefia, but then you do also you often have people who are still, in a sense, dependent on opioids, because if they abruptly stop buprenorphine, they're going to go through withdrawal, and they really have to be tapered off. Sometimes they just maintain them individuals on buprenorphine. Methadone is a full agonist, so in a sense, you're substituting methadone for the opioid that you've been misusing. In the tobacco, there's varenicline, which is another partial agonist. So it's like buprenorphine. Buprenorphine is to opiates like varenicline is to nicotine. And it actually works. It's been proven to be effective. It not only blocks the rewarding effects of smoking if you start smoking, but it blocks the withdrawal associated with cessation of smoking, just like buprenorphine blocks the rewarding effects of opiates if you start taking them, and blocks the withdrawal if you stop taking opioids. So that's a kind of brief overview of the medications that are available in addiction. I'm very positive about partial agonists because I think they can occupy the receptor and they have less efficacy in activating the receptor, but they cling to it really tightly, so nothing else can get in there. And so, I think there are efforts around the world to develop better partial agonists. There's efforts in the marijuana field to be looking at antagonists that attack, only one of the second messenger systems, and it will hopefully have similar effects as a partial agonist, or there may be allosteric modulators where you bind to a different site than the primary site that could also act as partial agonists. So, I think there's some hope coming along in basic research in medications. But they're not only medications, there's behavioral treatments. Cognitive behavioral therapy is a very effective treatment for hyperkatefia, but you have to do it. I mean, you have to, I would go so far as to say that Alcoholics Anonymous is a reasonably good treatment for hyperkatefia. There's nothing more powerful as a reinforcer to make up for that deficit in reward than another human being. And so you don't have to do Alcoholics Anonymous. You can do other 12-step programs. You can do other group programs. You can go to outpatient programs that have groups. But working with other people who are going through the same suffering that you've been going through and working through how you are using alternatives and rebuilding your reward system and re-establishing a normal baseline for your stress system. Any way you can do that. Mindfulness is being used in conjunction with cognitive behavioral therapy, sometimes on its own. And I hate to tell you this, and I say this a lot, but if you were to ask any of the other 26 institute directors what would be good for their disease, whether it's heart disease or gastrointestinal disease or depression or, you name it, they're going to say exercise. And so, I'd say the same thing about addiction. Exercise is great for your body. It's great for your brain. It gets the juices flowing. It occupies you in a very healthy way to instead of sitting around ruminating over, the negative thoughts that constitute the cognitive part of hyperkatefia. So I think those are the, and I'm hopeful. I mean, I know we're funding research in this area, but I'm hopeful that elements of telehealth and telemedicine, things like magnetic stimulation of parts of the brain as it gets more sophisticated, better behavioral techniques, and again, medicines that can reestablish homeostasis in your emotional systems. I think those are all going to be future treatments for addiction.
It's really thorough, and you're speaking to the choir when you speak about all those things, and especially social connectedness, mindfulness, exercise. We really encourage those things for our patients too, because we've seen them work, and again, time too. Just encouraging people that time will help them get better, and I'm sure you've seen that in studies as well.
Yeah, time. That's a really important point you raised. We forget about the fact that the brain, even though we don't grow new neurons, the brain is plastic. And what we know from the alcohol field is that individuals can recover. They can recover cognitive function to be just like a person who doesn't have a history of alcohol use disorder. And I'm talking about, moderate to severe alcohol use disorder. But when you image their brains, and this was work done by E. Sullivan and Dolph Efferbaum at Stanford, when you image their brains, the people who had a history of alcohol use disorder and the people who never had a history of alcohol use disorder are using different pathways. So where are you two located? What part of the country?
We're in Utah.
Oh,
different parts of Utah, but Utah.
Well, I-70 probably goes through Utah or something like that. So the individuals with no history of alcohol use disorder are using I-70, but the people who have recovered from an alcohol use disorder are using the side roads, but they get there anyway. They get there just the same. The only difference is the ones in recovery are always vulnerable, because maybe the stressor will be much larger and they're lacking I-70. Okay. And so we need time for those additional strengthening of circuits to kick in. So that's the time connection.
You can tell us a little bit about some of the public health policies surrounding like alcohol use. And are there any particular ones that you would like to see implemented?
Well, I'm not allowed to comment on policy as part of NIH. So, we do study policy, and I can say what we've studied is that, anything that limits the availability of alcohol generally decreases drinking. All right. So, if an area around a school is full of outlets where people can go and get alcohol versus an area around another school that has no outlets, you get the picture. So availability is a key issue, and you can extend that to carding of young people. You can, are you allowing people fake IDs to buy at bars. So those are all factors that contribute. And outlet density correlates with drinking. Okay, flat out. There are complicated relationships with the pricing. So, it's not a simple one-to-one relationship, but in general, the more a commodity costs, the less the commodity is used. With alcohol, it gets tricky because there are low cost versions and high cost versions and so on and so forth. But, again, those are anything that limits the availability in a policy, it can be effective. We have what we call the College AIM, which was put together before I came to NIAAA. So that was over 10 years ago. But it's a list of prevention options on the individual basis for universities and colleges, and a list of community options. And so, outlet density carding, availability of drinking places on college campus would be in the community domain. Something you may have even taken called alcohol EDU, and those kind of prevention programs are some of the individual ones. And we list all of them. It's on our website, and they're listed by effectiveness and also by how much they cost as programs. But that gives you some picture of some of the things that help prevent. And many of them involve, elements of policy that can be implemented by a local community, by a university itself, and so forth.
No, so it's a great resource, yes.
So what we do is we study policies to see what effects they have, but we can't recommend policies on our own. Well, that's up to the voters to do with their community and decide how they want to approach it.
Well, it's interesting because, like we've seen on the minimum legal drinking age, and how, and we see that in practice, that the delay when people are first exposed to alcohol, because there's this trend now, this very disturbing trend, I have to add, where if parents will just monitor alcohol use of teens and provide it in the home in a safe place, that's somehow like more acceptable, which is but then studies which you monitored and conducted, which we've seen, and we see personally, because many of our patients that we're doing intakes on much later, this early alcohol exposure, I don't need to tell you this, on with very adverse outcomes. And so having those older minimum legal drinking ages is associated with less risk of abuse and less risk of heavy use later. So there's that we've seen, and then I think we've seen when other countries, I think you cited on your website that even New Zealand, when they lowered their drinking age, there was a study that from 20 to 18, they saw an increase in teen drinking. Am I correct there? So
I don't remember the number myself on the New Zealand study, but absolutely, we've had a steady straight line decline in highway deaths due to alcohol since Reagan. It was Ronald Reagan instituted the 21-year-old drinking age. And we're going to be monitoring what happened in Utah, because I believe they've changed one of the laws there associated with drinking.
The legal limit for alcohol here is different. It's 0.05 as opposed to 0.08. Maybe that's what it is.
That's the one. So we'll be monitoring how that changes drinking patterns as well. So that's what we do. Absolutely. And you're absolutely correct about the minimum drinking age. I mean, that was a big effect and remains so. And a number of European countries now are going the other direction. They're raising their drinking age. And then the hosting party idea that you can train young people to drink properly is completely false.
Yeah.
I've never seen a positive study on it. And, this idea that in Europe, they can train their young people to drink properly is simply false too. I have a very close relationship with French neuroscience community and addiction community, and they have as big a problem with binge drinking in France as we do with young people. And, it's just not true. And even some of our latest studies indicate that even individuals who have a couple sips of alcohol are more likely to have problems later on, much less, actually engaged in drinking. So, as one of my colleagues says cynically, the hosting problems actually train people to binge drink. It's not the other way around.
Absolutely. And so this brings up something that we're both really passionate about, and you are too as an organization, is just messaging and changing kind of public messaging, which kind of ties into harm reduction, which we associate more with opioid use disorder and stimulants. But, we're interested in how the NIAAA has really seemed to have expanded its reach in terms of resources and messaging about the danger of alcohol, especially to vulnerable groups, more vulnerable, like women, pregnant women, adolescents, older adults. And, we're frustrated all day going around treating mostly alcohol use disorder folks at an age where people are mostly concerned about opioids. And we're not, of course, disregarding the harms related to opioid use. But is there anything that you think will further this messaging about the fact that alcohol is extremely dangerous to anyone? Just depends on the spectrum of danger, really, and according to vulnerability.
Well, one factoid, as I call them, that really seems to get the attention of audiences when I do public lectures is actually from one of our co-institutes. And that is NCI, the National Cancer Institute, now attributes 5 to 6% of cancer is due to alcohol. And, we've always known about breast cancer, increased probability in females who drink, and it's incremental. The more you drink, the higher the probability. We also always known about esophageal cancer, especially with the acetaldehyde peaks that are associated with that. But there was a news thing today on bowel cancer, and so that gets people's attention. But to take it back a step, from little individual vignettes, we've made a concerted effort. I think it started just probably prior to the pandemic, and the pandemic really exacerbated hyperkatefia, if you really want to know. I mean, the isolation, the stress, the worry about getting infected, the worry about your job being there when things got back together, and all of these stressors really, we had a big jump in alcohol consumption and a big jump in deaths associated with alcohol. And it really brought home what we had already started planning to do, which is this changing the conversation about alcohol, we call it. It's our program. And, the Dry January movement has really caught on and got a lot of press this year. The first week in January every year, I do 20 press interviews on Dry January in one day, one morning, long morning day, for outlets all over the country. And it's really starting, I think we're starting to get some traction in this regard. I think people are starting to pay attention. But, we got a lot, we have more to do, and we're struggling with how to do that, just like you are. I'll tell you my dream. My dream would be that alcohol would be considered the 5th vital sign in a primary care or any health clinic's office, and that the physician or nurse's assistant or nurse or physician's assistant or anyone, even clinical psychologist, board certified addiction medicine specialist, it doesn't matter to me who asks the questions, but if you just ask people how much they drink, how much their friends drink, and then actually do some intervention, like maybe some element of motivational interviewing, like, sir or young lady, some of the things you've come to the office for today could be due to your alcohol consumption. Or do you realize how much money you're spending on alcohol each week if you're drinking that much? You could do a lot of fun things with that. Anyway, you get the picture. So, my dream is that, second dream is that, I want to try and educate Americans on what is a standard drink. Because, the old cartoon where somebody's holding a glass of wine and it's the size of a liter bottle and they say, I only have one drink a day. But, I don't know that people really understand, 5 ounces of wine, 12 ounces of beer, 12 ounces of a seltzer, 1.5 ounces of distilled beverage. That's a drink, not 3 shots. Okay.
Yeah, we get a huge response from medical students when we teach addiction medicine modules on what a standard drink is, because of course they all, as well as what the definition of binge drinking is. We always get a lot of chuckles and, elbows in the ribs, because even our own, colleagues and medical students, residents don't understand this concept. And I agree with you from a clinical perspective. People are hungry for education, and it's amazing how misguided they are on the effects of alcohol. Like we see a lot of females, because obviously Darlene and I tracked that population, and women just don't know that alcohol contributes to breast cancer risk, or is responsible for their hypertension, or contributes to their anxiety and insomnia, or their rosacea. So it's just, education is key, and adding it as a 5th vital sign, that's wonderful.
We support that. I love it.
Yeah. We'll further the work in the podcast, absolutely, by talking more about it.
And the other factoid that goes with that is that women are more vulnerable than men. Multiple reasons, obviously, the blood alcohol levels tend to go higher for women for body distribution, water distribution reasons, but they also seems to be some increased vulnerability above and beyond that for a whole variety of everything from comorbidity with depression to liver disease. So, it really is. And we're now finally, I'm ashamed to admit, but we're now finally studying both females and males in preclinical basic research, just like we've been doing in clinical research. And finally, in clinical research, we're actually analyzing the data between males and females, which we never did before. So, I hope that we'll start to understand some of the bases for those differences as well.
I think we'll just cover some of the resources also that NIAAA has. Some of them Paula and I know we have used for years. I do have to make just one comment. I love definitely the dry January is catching on. I think the first time ever I have had 2 patients that showed up in my office specifically just saying that they were doing dry January. And it was actually really kind of nice for me. And I just give them out the Rethink Your Drinking pamphlets that I've been giving out for years. But it was actually nice that it was something that the patient came in asking for help. And I was like, well, you know what? Here you go. Let's talk about this. So that's a fantastic resource that I have used. And I think it's exactly what you talked about, that can we just ask, about the patient's alcohol use? And that's a regular thing. And yeah, I kind of sound like a broken record with my mid-levels whenever they come to me with any patient with out of control, like hypertension, or their blood counts off, or they have any kind of other medical condition. I always ask, well, what's their alcohol use? And they're always like, ugh. And I'm like, it's always the alcohol, so they're kind of always annoyed with me about that. But that's why I couldn't just say it better the way you did. So I appreciate that. But other resources, what other messages should we be getting out there?
Yeah, well, I'm going to give you a couple, but just to mention that, on the drive home, they do think about the question you asked them too. So, it's not, even though you get grief for it, just so you know.
We do.
And we all tend to lie probably a little bit when somebody's asking us about something that's not good for us, but we think about it, hopefully. Yeah, so Rethinking Drinking is one of our most popular. I mentioned College AIM, which is for universities and college administrators, but anybody sending their child to college or university might want to take a look at it. And then we have the NIAAA Treatment Navigator. And we did this in collaboration with the SAMHSA, Substance Abuse Mental Health Services Administration. But it actually tells you what is an alcohol use disorder, the spectrum, tells you about the spectrum of treatments, which we've discussed. But it also, you can type in your zip code and find a treatment facility in your locale. So it's something people may want to check out, maybe not for themselves, maybe for a loved one. And then for you two, I'm assuming you've seen our HPCR, as we call it lovingly, but it's the Healthcare Professional Core Resource on Alcohol.
Yeah.
But, anybody could look at that. It's pretty much everything you wanted to know about alcohol. And we spent most of the pandemic working on that. And so if you want to know what NIAAA did during the pandemic, that's one of the things we did during the pandemic. And, it's very comprehensive. It covers everything from how to do a screening, brief intervention, referral to treatment, talks about the medical conditions that we three have been talking about. It talks about what is an alcohol use disorder, talks about the different treatments, which we covered a bit today, a little bit of biology and neurobiology. There's even a whole section on drug interactions. What pills should you not take when you're drinking alcohol, or what pills that you are taking you shouldn't be doing alcohol with, et cetera. So, I highly recommend the HPCR. But in general, the simplest thing is to just type into your search engine NIAAA, and you will find everything on our website. And, anyone who looks at our website and still has questions, there's a place to interact with NIAAA. We'd love feedback. It's a living document. We can change it. But all of these, Rethinking Drinking, the Treatment Navigator, the HPCR, they're all on the website, so they can be found.
And also you can earn CME from the Healthcare Core resource as well, which is really an excellent resource. And we put it out on our podcast as a resource for our learners as well. It's excellent. And all of these are available in Spanish too, of course. So that's also important for folks to know, especially in terms of the actual product, to give people pamphlets. And we give those out in our rural county jail. So just, we have those circulating down in little parts of Utah. But thank you for that. The resources are valued and definitely used. So
yes, absolutely.
You guys are two of the most informed individuals I've had interviews with in a long time. So I'm very pleased to do this.
We'll take that as a compliment.
Thank you so much.
That was meant as a compliment.
Thank you. Yeah, no, thank you. We're passionate about the message, and we love our work. And so it's really wonderful to be aligned. And we're evidence-based. We try and deliver evidence-based information out for free to people who want to learn more, because we realized our colleagues, our medical students, our residents really don't have a great fund of knowledge around addiction medicine. And that's why the stigma perpetuates. People don't access treatment. And we want to, in some small way, change that. So we really appreciate you joining us, though, Dr. Koob, as a busy person. And we value that you were able to do that.
Well, it's been a real pleasure talking with you, and that's another compliment. So thanks for having me today, and thanks for your interest, and thanks for everything you're doing to help educate the public in this domain and help your own patients. So greatly appreciated.
Thank you. Thank you so much. We appreciated all your knowledge and teaching us over the years. So I can't thank you enough for your time today.
Until next time,
Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Content of the podcast are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on the show are those of the Addiction Files and not of our respective employers.